trainee in Sudan, this lecture about the TE in our daily clinical practice. I hope it will continue in the education. We are very happy to participate in this educational program. As I told our fellow Abdullah that Saturday or Friday and Saturday we are free. So during the daily we are so busy, but in these 2 days we can participate inshallah in teaching program. As you know, that all these modalities in our daily practice in cardiology is important, starting from M mode, like this slide, because any modalities has its own advantage and disadvantage. The M mode has very high temporal resolution. The T also has very high resolution, temporal and spatial resolution, because of the privilege that it is just behind the heart. You put your probe in the esophagus, and you will be just beside the heart. The depth is very short, so you are very close to the heart. So the depth is short, is low. The frequency will be higher, and the resolution will be, of course, better. So you will have a very excellent, brilliant image if you compare it to transthoracic echo. Most of the time, the views are very poor by transthoracic, but when you put your probe in and you see the view, you can find the pathology very clear, especially in the posterior structure, like the mitral valve, which is a posterior structure. So the pathology, it will be very clear. So besides that, it is a portable. You can do it in the ICU, you can in the OR, any sick patient, any patient hemodynamically unstable. You cannot send him for example, for CT or MRI or these higher modalities. Just bedside echo, transthoracic or TE will give you the answer. Of course, any modality has disadvantage. The disadvantage of the TE is that it is semi-invasive. It needs, of course, moderate sedation. It is complementary to the transthoracic echo. So first you do transthoracic echo. If you have any suspicious of any serious diagnosis, you can proceed for transesophageal echo. So initially, when you start the patient refers to you for transesophageal echo. So you have to have clinical data. Why this patient refers to you? What is the indication for TE? The referring physician, for example, refers this patient to you because he suspected infective endocarditis, and by transthoracic, he cannot see anything. The resolution of the transesophageal echo is very high. It can detect up to 1 to 2 millimeter masses. So if you have very small vegetation, 1 to 2 millimeters, it can be detected easily by transesophageal echo. So you proceed for TE, and if it is negative, there is no vegetation, now confidently tell him that this is not infective endocarditis. If still there is a high clinical suspicion for infective endocarditis, i.e., if there is positive culture with an organism that is typical of infective endocarditis, like Streptococcus viridans or Enterococcus or Staph aureus or one of these HACCP group. Okay, we can repeat the TE after 10 to 12 days, and if it is still negative, no vegetation is still, definitely it is not infective endocarditis. Look for other causes of fever. brucellosis or any other causes. So you have to, before you go to the yes, before you go to the sedation, and this start to communicate with the patient. Ask him about his, for example, we can take infective endocarditis because it is one of the most referring indication. Start to ask the patient about the symptom of infective endocarditis, any weight loss, any fever, any sweating. If it is highly indicative of infective endocarditis, then you look carefully for vegetation. Vegetation, of course, all we know is that it is in the upstream. For example, in the mitral, the MR jet go to the left atrium, so it will be in the left atrial side. Tricuspid, you look in the tricuspid valve in the right atrial side, and so far and so forth. So you describe the procedure for the
Sorry, Dr. Wahid.
patient. Yes.
We cannot share the screen.
You cannot.
انت مشغل باوربوينت دكتور رشيد ولا بس فاتح الفولدر؟
Sorry, it is not. شغلتها لكن I don't know.
كده جرب شير سكرين وبس تاكد انك يور شيرنج الباوربوينت لانه نحن بس شايفين الفولدر اللي اسمه فيه ايه.
I'm sorry.
لا ما في مشكله.
Sorry. Share screen. Stop share. You can see.
ايوه كده مظبوط.
Okay. Okay. So okay, that's good. So you can start again. You can see now.
Yes.
You can see, that's good. Okay. So before you proceed for moderate sedation, start to ask the patient about the symptom of, for example, infective carditis, and you start to describe to the patient that we will give you some moderate sedation. You will be fully conscious. You can feel everything, and you can communicate with us. Whenever we ask you to swallow, just swallow, and it will go directly to the esophagus. So you explain to the patient the procedure, and you start to tell him about. Of course, you take a consent from the patient. Fortunately, the TE has, as I told you, it is one of the safest procedure. In the last, maybe Hatim will confirm with me. In the last 5 or 6 years, we are working at the consultant in Cardiac Center. We never confront any mortality case. The mortality rate is very low, 1 in 10,000, and the other complication all can be treated. For example, if you have some hemodynamic compromise, when you start to give sedation with midazolam and fentanyl and all these, the patients start to be a little bit hypertensive. So you guard that by giving the bolus of fluid. Of course, when you start to the baseline echo for the patient transthoracic, the ejection fraction is very important in this patient. If the ejection fraction is normal, you can give IV fluid liberally. You can give 500 to keep the blood pressure in the higher side. Then when you start giving sedation, the blood pressure will be normalized. So give IV fluid liberally if the patient has normal LV function. But if the ejection fraction is low, for example, he has DCM and he has MR, and you want to know what is the cause of MR, just you can give boluses of 200 cc, but with caution, of course. And then some patients, if they are not reassured by the doctor, and telling him that this is a simple procedure. We'll give you sedation. I will introduce small probe to your mouth and esophagus, and it will be like a small piece of like less than 1 centimeter. It will go directly to the esophagus. He will develop hypertension. He will be tense, and the blood pressure will go up. So if it will go up, it will be better for you that you can give sedation comfortably. Then sometimes when you are giving diazepam in a patient with a background of cardiac problem, DCM, ejection fraction low, or he has some respiratory problem, COPD, these patients usually develop hypoxia, bronchospasm, and laryngospasm. And if you give a higher dose of sedation, usually we give around 1 to 2 milligrams of midazolam, maximum 3 milligrams. A patient will be moderately sedated. If you give, for example, a higher dose in a patient with a liver or renal disease, he might develop deep sedation. At that point, the patient will develop hypoxia because he cannot protect his airway. So you can immediately revert him by flumazenil and naloxone, of course. Okay, so though a complication is very rare, but it can occur, of course, if you are not gentle with manipulation. The trauma usually occur in the mouth, so be sure that the patient has no denture and he has no artificial teeth. If any, you can remove it. If it is not, fix it. And whenever you pass the pharynx or the larynx and pharynx, when you enter to the esophagus, the probe will go very smooth. If you have any resistance at any point, it stops the procedure, because sometimes there might be a diverticula, or there might be a tumor, or there may be a obstruction at any point here. It can cause a laceration and perforation. And there is a reported cases, very rare cases of perforation to the esophagus. And as I told you, in the last 5, 6, 7 years, we are working here in the Prince of Time. We never saw like this complication, because we are very cautious regarding the introduction of the probe. Of course, we have to take a very good history. If the patient has any symptom of dysphagia or some esophageal surgery before, you have to stop this, to refer him to other modality. So the TE protocol, as we said, you have to give him moderate sedation, moderate conscious sedation in form of topical, first topical anesthesia, and then you start to give small doses of midazolam, 0.5 or 1 milligram, according to the age of the patient and the LV function. If he is young, he will tolerate good doses. You can start with 1 milligram. If the blood pressure is good, for example, BB is more than 120, you can start with 1 milligram. But if you start with the baseline blood pressure of 90 or 80, first give him fluid first, improve the blood pressure if the ejection fraction is normal, and then after that, you start to give him small doses of midazolam, 0.5, fentanyl, 25. Sometimes the ICU or the anesthesia people, they are giving ketamine. And if you think that the patient from moderate sedation went to deep sedation and his saturation became low, less than 90, this is a serious problem. You have to correct, you have to revert him immediately by clomazanil and naloxone. And of course, you have to have a nurse with you, and sometimes you need a sonographer or other doctor with you to acquire the views. You need to monitor, of course, the blood pressure after each dose. When you give 1 milligram, you check the blood pressure, you see the response. If the blood pressure is maintained, you go higher till the patient became moderately sedated. Then you introduce gently your probe. As I told you, 80% when you put the probe in and you ask the patient to swallow, it will go to the esophagus. Definitely, it will go to the esophagus. And when we are working in ICU before, the most difficult part for us is the obese patient. Here, no. Here, the obese patient is very good because he has short neck. The probe, when you put it in, it will go directly to the esophagus. This is one of the questions that always they brought it in the exam. What is the absolute contraindication for TE? Absolute contraindication, any pathology in the esophagus, any perforation, any laceration, fistula, diverticula, obstruction, because whenever you have this pathology, when you put your probe and you push it with the resistance, it will cause trauma. So it should go smoothly. If it's not going smoothly, abort the procedure, and you can refer him for endoscopy to see what is the cause of his the resistance. Of course, you have to give him good sedation before you decide this decision. Then, of course, when there is I can see you the probe. The probe, of course, has two knobs, one big and one small, and there is one metal to make it flexible or fixed. When you introduce your probe, you usually make it in a not fixed position, because if it is fixed position, when you push, it directly causes penetration of the esophagus. So make it flexible, it will go smooth, and I reassure you that the complication is very rare. Then, what is the relative contraindication? Any esophageal varices, although is relative contraindication, but if it is grade 3 to 4, you have to avoid TE. But 1 and 2, you can proceed. Upper GI bleed, if you know the cause of upper GI bleed, for example, peptic ulcer, all the views you are getting that give you the answer in the upper esophagus. So no worry, you can go for that. If you have coagulation problem, sometimes for hemoglobin of 8, some consultants, they said, no, I will not do it. But if you know that this patient has, for example, mechanical valve and has hemolytic anemia, and the MCV is high, 95 or 100, and VTIC is high, this is anemia because of hemolytic anemia. You want to do TE to rule out the valvular leak, you can proceed, of course. A platelet, if the platelet is less than 100, any major trauma can cause bleeding. If less than 50, any minor trauma can cause bleeding. So if less than 20, spontaneous bleeding can occur. So unless it is strongly indicated or highly indicated, and you need to answer a major question, a major decision, for example, dissection, better to keep the platelet more than 100. INR, usually the patient came to you, mechanical valve or atrial fibrillation, keep the INR between 2 to 3, it is safe to do it. We did, me and Hatim, INR of 3.5, but there is strong indication for that. But if no strong indication, you can wait till the INR. You hold usually the warfarin 1 day before to keep the INR within therapeutic range 2 to 3. Then hernia, spinal disease, and all this is not, it is all relative contraindication. This is area for question in the exam. So what is the clinical indication? We can go through it step by step, so not to waste time. Infective endocarditis, if you have if you are suspecting infective carditis and the transthoracic is poor window and pure image, and you cannot see the vegetation, you proceed for TE. If you have persistent bacteremia with a typical organism, if you have an ICD or pacemaker, and you want to rule out infective endocarditis, go for it. Likely there is vegetation if there is high clinical suspicion, and especially if you have positive culture. EB procedures are daily. We are doing 2-3 cases for the EB people to rule out LS thrombus before cardioversion. Left atrial appendage is the most powerful indication for TE, but any other modality cannot rule out thrombus in the left atrial appendage except TE. Predict success of if the LA is huge, even if you do cardioversion, it will return back to atrial fibrillation. Watchman device, you have to do full comprehensive study for the left atrium, sizing of the left atrium in different view. We will give you views on that. Intraoperative, of course, post repair, post mechanical valve. Patient develop, they cannot win him from bypass. You need to do TE to see any regionality, to see the RV function, LV function, to assess the mechanical valve, native valve, mitral valve prolapse, especially repairability, repairable or not. Source embolization, always the neuro people refer patient for us to rule out the source of embolization. Congenital heart disease. Let us go to the business. Now you have the probe. You have 2 knobs in your hand. Thus you hold it like as if you are holding your pen, and you can see there is 2 knobs. One big knobs, it will cause flexion and extension, or anti-flexion or retroflexion. Anti-flexion anteriorly, retroflexion posteriorly. And then you have up and down. You push your probe from the pharynx to the esophagus till the 30. When you have 30 centimeters, you are in the esophagus. When you push it down to 40, you are in the stomach. You go up 25, you are in the upper esophagus. You go to 30, you start to be in the mid esophagus. And then when you reach 40, you will be in the stomach. 45 will be in deep esophagus. So deep stomach. Okay. So, and this is a multi-plane probe. All the probe now is multi-plane. Just when you put your probe in the esophagus, okay, then you can just, there is 2 nodes, up and down. When you put, when you press up, it will go from 0 to 30 to 90 to 180 degree, and the other one will go back from 180 to 0. So there is 2 big rotatory knobs for anti-flexion and retroflexion, small one for right and left. Usually we don't use small one. Rarely we are using it. Usually we are using only the big one, unless you want some views difficult to be obtained. And then you go down and up. Okay. So here now I push my probe. I successfully intubate the patient. Patient is under moderate sedation. He's conscious, and he's awake. He's responding to your command. You make him comfortable. Everything is fine. We are now in the esophagus. 70% of the job, or 80% were done. So just be patient with us. 20 minutes will finish our study. So when you are in the upper esophagus, you are seeing the big vessels, the aorta and the pulmonary. When you are in the mid esophagus, this is the one you can get all the views from mid esophagus. And when you go down to the stomach, you get the gastric view. And when you go down to the apex, you are in the deep transgastric view. Then you do a good flexion, and you will get a 5-chamber. So we go to the basic exam. Now, according to what you want from the study, usually you have to have, anyone should make a plan when he starts to do TE. I want to, for example, to assess a mitral valve. Immediately I go to our target, I finish my study to assess the mitral, and then assess the remaining structure. First, because sometimes the patient will be unstable, for example, became hypoxic or hypotensive or not cooperative. If you give him sedation, of course, he will become cooperative, but sometimes you cannot give. Sometimes the patient pulls the probe. So first, examination should focus on the key diagnostic issue, and then additional views you obtain later. Of course, this is the all the views will go through it. We start, as we said, from the mid-esophageal view, then upper esophageal view, and then transgastric view. 3 only. Then upper esophageal view, mid-esophageal view, and transgastric view. Go. Start. Okay, so here, this is the first view you get when you put the probe in the esophagus at 30 centimeters from the incisor. From the incisor, 30 centimeters from the incisor, you will be in the mid-esophageal view. So the mid-esophageal view, you can see this is the 4th chamber. So the knot is still in 0. Still in 0. When you found this watch, this means that it is transesophageal echo. This is the difference between TE and transthoracic. And then our probe is here, posterior in the esophagus, behind the left atrium. So the first structure in the near field is the left atrium. So you can see the left atrium is very clear. The LV also here, the RV in your left side of the screen, and the right atrium, interatrial septum, interventricular septum. You can see a very clear, brisk views. You will never find like these views in the transthoracic. Then you adjust of course, your focus. If you are focusing on the mitral valve, you put the focus here in the mitral valve. If you are looking for the LV, you put it down. Then you start to assess. So what is going here? This patient, I will give you, for the sake of time, pathology and view at the same time that you can get benefit from all. So this patient is known SLE patient, young patient, around 40. She came with a shorter breast. They referred the patient because of shorter breast. We did transthoracic. We found a gradient across the mitral valve. We did this TE, and we found this. Any suggestion? Just quick.
Liebman endocarditis with kissing lesions.
Yes, salam alaikum. So this is a kissing lesion in the mitral. So 2 leaflets. So this is anterior leaflet. This is posterior leaflet. So there is a thickening in the tips of the anterior and posterior kissing lesion, typical of Liebman endocarditis. So this patient referred for ballooning. When we did this TE, we said, "Khalas, you have severe stenosis. Let us give you time and reassess you again after the maximization of the anti-SLE medication." They gave us all the immune-modulating medication. After a while, all these masses disappear, and instead of severe stenosis, it became severe mitral regurgitation. So it's Liebman syndrome, Liebman sac endocarditis. This is another. Now still you are in the mid-esophagus. You didn't move anything. You are your probe in 0. The omniplane the one you press it in your right hand. It is in 0 still. And you can get this typical 4-chamber view. And you can put color, of course, to see what is the pathology. This patient, they assess him for clip. You can find there is some mitral regurgitation here, but I'm stressing on the view. So 4-chamber at 0 degree, and this is the left side, this is the right side. You can see the LV is impaired, RV also mild impaired, and there is some MR coming from where this jet is a question. Now, if I want to assess the mitral regurgitation, I will start with 4-chamber. Why 4-chamber? 4-chamber will give you A2, B2. This is a little bit advanced, maybe for the echo board. A2, B2 to see the jet coming from A2, B2. So if I go a little bit before going that, you have this modality, the pipeline. When you put your X-plane to the anterior leaflet, you can see if there is any pathology. Now you can see here this pipeline. It is crossing the anterior leaflet, and in the right side, your right side, you can see the filial segment of the anterior leaflet. So this patient done mitral valve balloon in other hospital and came with a huge short of breath. So likely he has a rupture of the cordy. But I'm here stressing on still we are in 0. Still, I did focus, just I zoom on the mitral valve to see what is the pathology going on. I put X-plane. Actually, X-plane, you cannot do it if you do zoom, unless you do decrease the depth. If you decrease the depth, the image will become bigger. Then you put your X-plane, you will get the pathology clear here. This is filial anterior leaflet. No need for details for you as your level. Anterior leaflet filial. Then, if you, from your mid-esophageal view, just pull it 1 to 2 centimeters. When you pull it 1 to 2 centimeters, so you have 3 motion, we said, in and out. Now we are in mid-esophageal at 35, for example, or 32 centimeters from the incisor. You pull it to 28, 25, like that. You will start to see the aorta here. So this is a 5-chamber view. 5-chamber view. You see the aorta. You see 2 ventricles, 2 atria. Some of the RA here, RV here. Sorry, LA, RA, LV, RV. Besides the aorta, this is a 5-chamber view. How I get it is still I am in 0. Just I pull it a little bit up, I get 5-chamber. If you want to see to remember, where is it? Yeah, here. I'm in the mid-esophageal view. I will cut this. Then if I go up just 1 or 2 centimeters up, I will get the aorta, and I will get 5-chamber. Okay. So 5-chamber. 5-chamber is important if there is AR. Okay, and at the same time, the mitral valve, I want to assess the cause of MR. This is the same patient for clip. The MR is not coming from this scallop of the mitral, A1, P1. So when I pull it up, I will get A1, P1. So A1, P1 at 5-chamber. If I go down a little bit again, I will go to, again, 4-chamber, and I will cut A2, B2. So here, what is the pathology? Anyone? First, what is the comment on the LV and RV?
dilated RV. The RV is dilated,
Excellent.
and there is a device, it seems, in the atrial septum.
Absolutely right. So usually, if you compare the LV to the RV, usually it is 2/3. So the RV is 2/3 of the LV. When the LV starts to become the same size of the RV, it is moderately dilated. When it is bigger than the LV, it is severely dilated. So here the RV and RA are severely dilated. Also, the LA is dilated. LV function normal. RV function normal. The cause of dilatation of the RV definitely previous ASD, which was closed successfully by interatrial device. Absolutely right. Then still I am in zero. Still in the mid-esophageal view. I didn't change anything. Just the probe is inside the mid-esophageal view. I pull it a little bit up. I get 5 chamber. I will push it now a little bit down, 2 centimeters down before the stomach. I will catch this one. What is this structure? What is this? What is the most posterior structure? When you go up, you are going anterior. When you go down, you are going posterior. So what is the most posterior structure in the LA?
Coronary sinus.
Coronary sinus. So this is the coronary sinus. Excellent. So coronary sinus, when you get the coronary sinus, when you get a coronary sinus, you are cutting, and you concentrate on the mitral, you are cutting A3, B3. So, for example, if I'm assessing the mitral valve, from only mid-esophageal view, I can get the pathology. Where is the MR coming from? Is it coming from A1, P1 from the 5 chamber, upper esophageal view? Or if it is A2, P2, it's coming from A2, P2 in the mid-esophageal view. If it is coming from this view, coronary sinus view, or posterior or deep mid-esophageal view, it will be A3, B3. Okay. So again, whenever you lost or you cannot get the view, go to the baseline view. I went back again to the mid-esophageal view. This patient, if you remember, the one with Lippmann-Sachs syndrome, still there is some stenosis. Still, this is when he presented initially. There is only mild MR. Because of that, they refer him for balloon. But after the medication, he developed MR. So this is another patient. This is the one with post mitral valve balloon in other center. Now I start to move the omni plane from 0. I went just to 30. You can go 40 till you get the commissural view. Commissural view is a very important view. They call it commissural view because you are cutting the mitral in a plane that you get P1 here. This is the left atrial appendage in this side. So left atrial appendage beside P2 and P1 and A1. So this is the left atrial appendage. So here is P1 and the middle A2, and here is P3. So you can see the jet. This is not a typical, should be around 60. I will give you another view to see it well. So this is 60. 60, this is a commissural view. You see the left atrial appendage is open. So this is here the P1, here A2, in a P3. And you can see this mass. And there is significant mitral regurgitation coming here. So what you think this mass? Is it vegetation or thrombus? And how you differentiate?
Vegetation is close to the LA side.
Yes, it is vegetation. Yes, it is because it is lobulated. It is amorphous. it is not smooth. It is the atrial side. You see, it is in the atrial side, and there is associated mitral regurgitation. Associated mitral regurgitation. So if you find like this will tell you that it is likely vegetation. Likely. So okay, so we go more to 90. Now we, from the same view, we get midesophageal view. Just I'm starting to move the knobs here in my hand by fingers. I press it went to 60 here commercial view. Then I press more. It went to 90. 90 will give you the two-chamber view. The two-chamber view. What is the pathology here?
LA's thrombus.
LA thrombus. Oh,
LA appendix thrombus.
LA appendix thrombus. Because you did it
like a device. It seems like a device, Watchman device.
Watchman device.
Buying the whole
there is a hole here. There is a shaggy here appearance. There is pulsating mass here. There is a color going inside. There is something serious going on here. This is appendage. Yes, you are right. But this is not a typical. I'm sorry. It's not a typical view of two-chamber view. You two-chamber view, you will not see the aorta. This is not. This is a little bit clockwise rotated. Because of that, you see the aorta, and it is the big mass here. Because of that, you can see some part of the. I can see this is the typical view. This is a typical view of 120, a long axis view. But still, if you tilt it anti-clockwise, it will give you two chambers. When you move it clockwise, you will get the three-chamber view اللي هي حنشوفها في الصورة اللي بعدها. So here, this is the aorta, and this is the ascending aorta, and this is a huge collection of abscess formation in the aortic likely prosthesis. It is not clear here. I'm sorry for that. It should be a clear two-chamber to see. So I will give you more clear views. This is the same view, the midesophageal. Now we are moving from 0. We went to 60, commissure. We went to 90, two-chamber, and then to went from 120 to 130. You will get this view if you do clockwise rotation. If you don't do clockwise rotation, you will get this. I'm assessing now the mitral valve. Because I'm concentrating on the mitral valve, I am anti-clockwise rotated. I'm tilting posterior. But if I tilt it clockwise, it will go anterior, and I will see the ascending aorta and aortic valve. Now, I will give you more clear view. Here, this one, I went to 120 to 130, then clockwise rotation, I get this view. Nice view, اللي هي long axis view, اللي هي left atrium here, left ventricle here, aorta, aortic valve here, ascending aorta here, and there is a snake inside. What is this snake?
Dissection.
Dissection, excellent. So there is a dissection. There is a dissection flap, aorta, dilated aortic root, dissection flap. This is a typical. So by this view on this, sorry for the view, bad views here. Why? Because it is in the OR. Patient came acutely. They pushed him to the OR. They did it in the OR, and they found, of course, the transthoracic shows something. So and they proceed for, of course, CT. And after CT, patient pushed directly to the OR, and they found this dissection flap, and he went for surgery. The one, if you remember, the one with the, we don't know exactly where is the MR coming from in 0 and 60 on post ballooning. You see here, this 3D will give you the answer in only one shot. there is a filial A2 of the anterior mitral leaflet. Okay, so here, this is a long axis view from 120 to 130. Will give you the aorta, aortic valve, mitral valve, left atrium, left ventricle, right ventricle will be in the right side. And I can get the short axis with X-plane. How I get it? Just I would explain here. I would explain, I will get the short axis. Okay, when I get the short axis, it will give you the inflow and the outflow of the RV. The tricuspid valve will be here, the pulmonary valve will be here, the aorta and the aortic valve is here. What about the leaflet? The one beside the septum is a non-coronary cusp. The one in the RV is the right coronary cusp. The one here besides the left atrium, because posterior here is the left coronary cusp. The left main will be coming from here. So just explain it, you will get the short axis. Or how I can get the short axis by other way, I will go back again from 120. I have it. I don't have it here. How I get the short axis again? I will tell you from here. I will go back from 0, from 120. I will go down to 45. And when I went to 124, 45, how I get anterior? I said clockwise. Do clockwise rotation. You will go to the short axis of the aortic valve. So this is the second way to get the short axis of the aortic valve, and you get the tricuspid inflow and outflow, the pulmonary. Okay, so two ways: either you long axis, you put X-plane, you get short axis, or you go down to 30 to 40 or 45, and then clockwise rotation to get the anterior structure, and here's the aortic valve. Okay. This is إذا أنت ما طلعت من اليوم من المحاضرة شيء اطلع بهذه فقط. This is the most important view in TE. You will find difficult to get it by transthoracic if it is not impossible. So this is a bicaval view. Bicaval view. So you go back from 120 to around 190, and then again clockwise rotation. You will get superior vena cava, inferior vena cava, tricuspid down here, right atrial appendage here. Okay, there is a line here. It could be pacemaker, it could be a dialysis line. Anyhow, the pathology here, this is the mass in the left, in the right atrial appendage. Okay, so this is a bicaval view. Bicaval view. Superior vena cava, inferior vena cava, left atrium here, right atrium here, and the interatrial septum is here. If there is any ASD, it will be very clear here. Like this patient, there is an ASD. This is post mitral valve clip. So this is iatrogenic ASD, and the shunt from the left to right or right to left. From right to left. Why right to left? Right to left, because likely the patient has pulmonary hypertension and the jet going from right to left because of the severe pulmonary hypertension. Okay, this is, if anyone get it, he will be the star of this lecture, of the meeting. So this is a bicaval view. Superior vena cava here, inferior vena cava here. Patient became, they did for him TE because he has severe RV dilatation.
Sinus venosus ASD.
يا سلام عليك يا ده منو ده؟
دسوقي.
دسوقي يا سلام عليك يا دسوقي. This is sinus venosus ASD, which you cannot be diagnosed by any modality except TE. You go to the bicaval view, you see this is this superior, this is superior vena cava, inferior vena cava, left atrium. It is directly opening from the left atrium to the superior vena cava. This is sinus venosus ASD. Excellent. Yeah. Then after we finish from the mid-esophageal view, we'll go down. As the patient, I will go down to the to the 40, around 40. You will go to the transgastric view. In the transgastric view, you get the short axis. Short axis, transgastric view. You put explain, you will get long axis. Instead of going to 90, just put explain, you will get 90. Okay, and then if you go a little bit up, you will get the papillary muscle, or in, you get the papillary muscle. So this is, as we know, this is we are imaging from above here. This is the esophagus. So the esophagus here, and this is the left atria. Sorry, we are imaging here. So this is posterior. So this is will be the inferior wall. This will be anterior wall. So this will be posterior-medial papillary muscle, and this will be the anterolateral papillary muscle. So we are cutting at the level of the papillary muscle. Go down a little bit, or up a little bit, to cut the mitral valve. When you cut the mitral valve, you can see the chordae. You can count even the chordae. This is the pathological problem here. This patient post-mitral valve ballooning, you can see there is a chordae rupture. And the anterior leaflet is lial here, as you see, lial, and multiple chordae rupture. So this is the cause of the severe MR post-mitral valve balloon. They inflate at the level of the valvular apparatus, not at the level of the mitral valve. Besides, it is not a good patient for mitral valve balloon. His score is more than 10. Okay, so go more, a little bit up. Where is the MR jet come from? This is in OR. They ask you this question. Is it coming from the anterolateral commissure or posterior commissure? How I know? This is the posterior here. This is the RV here. So this is the posterior medial commissure. This is the lateral wall. This is the medial wall. This is the anterior wall. So this is anterolateral commissure. So this is anterolateral commissure here. Posterior medial commissure here, posterior medial commissure P3, A3, anterolateral commissure A1, P1. The jet coming here from the posterior medial commissure. Okay, then this is, I'm sorry, there is no live image for this. Then I will go deep with the 0 degree. 0 degree, still in 0 degree. I went back to 0. 0 degree, I went and I get short axis. I went up, I got a mitral valve. I went down a little bit, I got papillary muscle. I will go down a little bit deep transgastric till the apex. Then I do good anti-flexion, good flexion. I will get this 5-chamber view again, like the one you get it in the transthoracic. This is the aorta here. This is the RVOT here. This is the LV here. This is the LVOT. This is the best view to get the gradient in aortic valve. If you have aortic stenosis, this is the best view to get the gradient. You can get it also from 120, 130. You get the same long axis view, but it is not aligned to the beam of the ultrasound. So this is a very important view. You have to master to get it. It is very important. It will help you when you are assessing the patient post-aortic valve replacement for any valvular leak, any leak, and to get the gradient. And then we'll go to the descending aorta. This is the descending aorta. When you do, this is the only one you do, then you move clockwise rotation, you will get the short axis of the aorta, is the descending aorta. Then you start to go up, 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 till you reach the arch. And here, this is, they call it blind spot. Blind spot, because by transthoracic, by TE, it is a blind spot. By transthoracic, you can get it by suprasternal. So you start to see like this patient. This is the when I went from 0 to the other way to the descending aorta, I get this pathology. What is this pathology?
Dissection flap.
Dissection flap in the
Dissection flap.
Excellent. Dissection flap in the descending aorta. There is a lumen, false lumen, and true lumen. How I know the false and true lumen? And here the exit and entry point. You have to get the exit and entry point. And you have in TE, if you have dissection, you have, of course, to have 5 or 6 things by TE. You have to confirm first the diagnosis of dissection by seeing the dissection flap in 2 views at least. Identify the entry points and the exit points. The entry point is very important. When you close it, you stop the progression of the dissection. Determine if there is a coronary sinus involvement, right, usually, and if there is any regionality, if the coronary sinus involved, the RCA, if there is regionality, and to assess the aortic valve, if there is aortic regurgitation, and look for effusion, pericardial or pleural effusion, and to assess the other valve before clearing the patient for the surgeon. And then you go, this is the descending aorta, you are going up, till you reach the arch. And if you want to assess the large vessels by upper esophageal view, 0, and then you move it to 90, you get the short axis of the aorta here, short axis of the aorta, and the pulmonary in the lung. And then if you go to 0, you get the reverse, the short axis of the ascending aorta, and the pulmonary right and left pulmonary branches. Okay, so we go fast. The mechanical valve, you know, by leaflet and or single leaflet on ball and cage. And this is the tissue valve. You see the all the type of tissue valves, the Carpentier-Edwards, mosaic valve. And what is this? How can I see? This is a mechanical or tissue or repair. How I know? Or it is native. If you see the 3 horn, come on, here it is a 2D TE. You can see only 2 horn in one plane. You cannot see the 3 horn in one plane. So you can see this 1 horn and second horn here. So if you see the two horn and there is no shadowing in the far field, this is a tissue valve. Usually, this is the importance of TE. The far field, the shadowing, usually in the far field. The transthoracic, the shadowing will be in the left atrium. In the TE, the shadowing will be in the left ventricle. So because of that, if there is any vegetation, if there is any paravalvular leak, it will be very clear by TE, unlikely to be seen by transthoracic. So here, this is a tissue valve. Why it is tissue valve? Because there is a horn, there is no shadowing. I will see you the other way. So this is how we see there is no shadowing. This is how we see you can see this is the horn here, and there is no shadow. Here, this is definitely mechanical valve. Why it is mechanical valve? Because in the far field, I can see the shadowing. So it is by leaflet, 1, 2 leaflet, okay? And there is some jets coming from the outside the sewing ring. There is a paravalvular leak here and here. So this is a mechanical valve with paravalvular leak. You have to rule out infective myocarditis in this patient. Okay, this is mechanical or tissue? Very quick.
Mechanical.
Mechanical, yes, because there is a shadowing here. There's a shadowing, so it is definitely mechanical. And what is the pathology? Again, paravalvular leak, severe paravalvular leak. Excellent. Okay, so this is I cannot find TE views for this. This is ball and cage. If you see a bulky mechanical valve and the gradient is normal, likely this is ball and cage. This is just for your reference. It is out of this. So what is this? Mechanical or tissue?
Mechanical.
Mechanical. And what is going on? What do you comment about the mechanical valve here? Is it normally a stable valve, you think, or unstable valve?
Unstable, rocking.
Yeah, it is rocking valve. There's a rocking valve, and there is a mass here, likely vegetation, causing rocking valve, causing paravalvular leak. So this is a rocking valve. There is another. Oh, nice here. Oh, very beautiful. This one is one of our cases recently. How to differentiate? What is your high? This is mechanical, tissue, native. What do you think?
Tissue.
Tissue valve, yes, it is tissue valve. There is two horn, but there is no shadowing. And what is going on? This patient, yeah, there is this leaflet is completely destroyed, and there is vegetation. This is vegetation. How I know it is vegetation? It is independent motion from the leaflet. Okay, repeat it again. So there is complete destruction of the leaflet, complete destruction of the tissue leaflet. Yeah, and there is two masses, one vegetation here, independent motion, oscillatory motion, and there is another one here. This is the leaflet that completely destroyed, perforated. We confirm it by 3D. And what is this structure here?
Atrial appendage.
Atrial appendage. Excellent. And this is the vegetation. Excellent. So here, what is this? Mechanical or tissue? Mechanical valve with mechanical valve with multiple also masses, likely vegetation, shaggy, independent motion, and this. What is this here? It is only steel frame. This is the old patient 80, just a source of embolization. This is lumbar secretion. You cannot see it by transthoracic. So here, this is actually normal functioning valve. This is the transthoracic, of course. Transthoracic mechanical single leaflet. Okay. Of course, what is this? Who will tell us what is going in the mitral and what is going in the aortic, or what is prosthesis they put in the mitral and the aortic?
Like disc.
This we didn't tell yet about this. Here, what about the aortic first? Start with the aortic. It's coming and going. Mechanical, because there's a shadow in here. Yes. What about the mitral? It's a difficult question.
The repair.
Yeah, salam alaikum. It is a repair. It's not a tissue valve. Why it is repair? You can see the leaflet, anterior leaflet. Usually they repair the posterior, and you see only one leaflet is closing and opening. So if there is one leaflet here and the other one is fixed, this is a repair mitral valve. And patient also has some MR coming through the leaflet, likely perforation, and there is another jet at the coaptation point indicating significant MR. And here, what is this? Tissue or mechanical?
Aorta mechanical.
Mechanical. And there is a paravalvular leak. And what is the view? Now we are in 150. So first you see the degree to see what's the view. And then you go to the, usually from 110 to 150 like that, you will find the 3-chamber long axis view of the LV. And then the procedure, TE is very important in the intervention. Now this intervention is the clip. This is a commissural view. They put the plane to get the long axis view, and here they will see the clip opening, and they can capture the mitral valve. And what is the other? This is very common in Sudan. What is this? This is 3D, of course. This is after the procedure.
This is BTMC.
Yes, this is this is mitral valve ballooning during the inflation of the balloon, and here this is the anterior. This is the left atrial appendage. This is anterior lateral commissure. They split it. Posteromedial here, and lastly, the most important or the strongest indication for TE is the left atrial appendage. The commonest, there's multiple, of course, you can review it, of course, chicken wing left atrial appendage, and this is how we can see it in the TE. And we have to do comprehensive study, starting from zero for the left atrial appendage. You have to open it. You go to the lateral, it is anterolateral structure, of course. You go, and this one, you need to have the three hand, all the three hand should be working at this point. First, you stress your probe by your hand, right hand, and then you do flexion, good flexion, to open the left atrial appendage, okay, and a little bit up and down to get the view. Now here I get it from zero, and then I do explain, and then I will go to the 45. I will get another view for the left atrial appendage, because sometimes you have multiple loops. You can find small thrombus here or there, and then I will go to 133 to get the biggest diameter of the left atrial appendage, and you put explain to see the small cavities in the left atrial appendage, and then you can do explain to see the 1 and 2 loops if there is any thrombus, and then you do pulse for the left atrial appendage. This is before the procedure, Watchman device procedure. They introduce the Watchman device. This is the right upper pulmonary vein. This is a Watchman device in, and this is after implantation of left atrial appendage device. We know that 90%, 95% of thrombus found in the left atrial appendage. By this patient came because of upper GI bleed and stroke. They cannot give anticoagulation, so because of that, they put for him Watchman device. This is before, this is after the Watchman device. And this is all the views. It is in your hand to go through it. All the views, how to get it. This is in your hand. And by this, I can conclude.
So Rashid, can we go back to the barbara leak in the water?
Barbara leak in the aorta, excellent. What is your question? Sorry. Yeah, here. So what is the question?
Just يعني ما بنعرف ما بعرف.
Yeah, if you find any jet, of course, it could be either intrinsic or extrinsic jet. Sorry, either barbara leak or intrinsic jet. If you, for example, here, this is repair and the aortic valve. There is some jet here. If it is inside, it is intrinsic. If it is outside the sewing ring, it is barbara leak. So here, there is a jet barbara leak. The other one, this one is a very eccentric jet. Because of the shadowing, I agree with you, it is very difficult, even for the senior to know where is the jet coming from. Is it from inside the struts or outside the struts? But this one we did, of course, multiple views from the transgastric and from the short axis, and you can tell from the short axis it is coming from inside or outside. Here, I agree with you. It is difficult because of the shadowing. I can see a jet, big jet coming, but is it inside, from inside or outside? It could be a very eccentric jet that you cannot localize exactly where is the origin. I cannot localize the origin because of the shadowing. But in the short axis, you can get it. And from the deep transgastric view, you can get it. Or you go to 145 degrees. Don't depend on one view to diagnose anything. You have to do many views to get your final conclusion. Because of that, you are the one diagnosis besides the bed. After you finish the diagnosis, you sit again, you review again, and you reach a conclusion about the final diagnosis. Is paravalvular or intrinsic? Usually mechanical valve, big jet like this, extrinsic like this, eccentric like this, it is paravalvular. If it is tissue valve, yes, it could be intrinsic or paravalvular, but because of the degeneration and this, you can have intrinsic. So, any question?
معلش دكتور رشيد، بالنسبة للإلي appendage
أيوة.
أنت قلت بنشوفها at 0 degrees, 40 degrees and 130.
Yeah.
هل بتمشي من upper esophagus, lower esophagus, mid esophagus, lower، يعني بتمشي كده ولا في نفس المكان؟
لا
كلهم mid esophagus.
هو كلها mid esophageal view، كلها يعني you have to go لأنها هي very anterior and very superior. So it is anterolateral. So you have to go up and rotate and make some tense in the left atrium, sorry, in your probe, and do good flexion, like the one you do it in the deep transgastric view. You do good flexion and some tense in your right hand beside the mouth of the patient, and you do some good flexion. You will get the appendage, and you get this is the right upper pulmonary vein. And now explain, make your life easy. You try to get the left atrial appendage from any view. For example, it is easy to get it from 133, for example. Okay, you get it from 133, and then you put explain here to see this loop, and you move your explain to this side, you will get this loop. So you can get it from different orientation, but all from mid-esophageal views for your answer. But you have to go up and down till you get your views. So this is, and before Watchman device, you have to do comprehensive study. You have to get it from all, because they are getting measurement from 0, 45, 90, 135. And then after that, you can do 3D also. You can measure it by 3D. And this is the left atrial appendage, and this is the left upper pulmonary vein. And then they anchor the wire here till they introduce the delivery device. Then they move it from here to the appendage, and then they put it inside. There is one view for this, yes, here. Then they put it inside. And it is good for patients with high risk of bleeding, and at the same time high risk of, and if you have high has bled and high risk of short vas, and the patient has upper GI bleed, or he has cranial bleed, intracerebral bleed, you put this device and you stop all anticoagulation after 6 months. Okay.
Thank you.
Welcome. This is all the type of the cauliflower and chicken wing. And okay, I hope that you get benefit from this lecture. Tea is a very strong tool. You have to use it in Sudan. You have to use it. And in Medani, as I said, there is a probe and there is a machine. I think if you don't, still you don't have a confidence to put the probe, 30% of the failure from the failure of intubation to the esophagus. You can ask the help of the anesthesia. They put the probe for you, and you get all the views. You get all the views. Quickly, you start with the mid-esophageal, and then you go to the 60 from the same side. And you don't move, just put it in the mid-esophageal, and then you can get all the views. Just increase the degree, 0 for chamber, 60, you get the commissure, 90 to chamber, and then aorta, sending aorta, by 120, 130. You investigate the aorta thoroughly. You go up, you pull the probe up, you will get the ascending aorta. You assess the aorta, if there is any aceroma, any dissection, any AR, all this can be assessed. So it is a strong tool in your hand. Please use it. Yeah. Good luck for all. Thank you very much. Any question?
شكرا جزاك الله خير دكتور رشيد. Very
Welcome.
nice lecture.
Welcome. Thank you very much.
Thanks a lot دكتور رشيد.
جزاك الله خير.
Thanks a lot.
الله يسلمكم.
شكرا دكتور رشيد.
Yeah, highly welcome. Thank you. You are highly welcome. Thank you very much. Good luck. اللكشر هذه ممكن ابعتها لكم في I don't know how to send it. I will ask مثلا in one of the or I can send it because it is contain a lot of videos. I don't know. It can be sent by drive or
I think by drive can be sent it.
خلاص I will ask someone to send it to you inshallah. And then you can distribute it between all the people. Thank you very much. And
Thank you.
the one also, the one I think it is here with me, the one for the I think one of the company Philips, or they make all these views in a good demonstration. You can imagine and you can try to practice. أهم شيء في الموضوع إنك to practice, to drive the car. When you start to drive, everything will go smooth, inshallah. Thank you very much. يلا تعال.